Welcome to the Longevity and Hormone Health Podcast with me, Dr. Fareeha Rizvi. I'm a consultant in diabetes, endocrinology, obesity, and general internal medicine. And every week I discuss an aspect of hormonal health that is relevant to you. And I often base these on real life cases from my clinic. So 2 days ago, I saw a 26-year-old woman who had been referred by gynecology for irregular periods. So today's topic is going to be everything you need to know about PCOS, or as it has recently been renamed, PMOS. So going back to my case, this was a 26-year-old woman who had been referred from the gynecologist with irregular periods and pre-diabetes on a blood test. Now, what is really interesting is that her mum happened to be with her, and her mum, my patient's mum, was a woman in her mid-50s, and she was already taking treatment for type 2 diabetes. So I took a medical history, and it quickly became apparent that my patient had a lot of features of metabolic disease. So metabolic disease is things like diabetes, cholesterol, blood pressure, the metabolic syndrome you must have heard of. I've talked about that a lot on my social media and on this podcast. So this patient of mine at 26 years old was already showing signs of metabolic disease. Over the last 2 years, she had gained around 15 kilograms in weight, giving her a BMI or body mass index of around 39. She had had a pelvic ultrasound scan which showed that both of her ovaries were enlarged, which both had a size of around 12 cc's. That's the ovarian volume. Then I looked at her blood test, which had been done by the gynecologist, and that showed a hemoglobin A1C of 6%. So that is already in the pre-diabetic range. Remember, when we look at HbA1c, that tells us the average blood sugar over the last 3 months. So you have a normal blood sugar, pre-diabetes, and then type 2 diabetes. And her HbA1c at 6% was in the pre-diabetic range. The other thing is, as I mentioned, her mum already had type 2 diabetes. So I'm thinking about this patient, my patient, and her long-term health. She has had irregular periods for the last couple of years, only getting a period maybe every second or third month. So some of you may know about PCOS, you may have heard about it, but what actually is it? So PCOS stands for Polycystic Ovarian Syndrome. It's recently been renamed to PMOS to include the metabolic aspect of the disease, but actually the criteria to diagnose it has not really changed. So to diagnose PCOS or PMOS, you need 2 out of 3 medical criteria. So the first is irregular periods or even absent periods. So some women of a reproductive age with PCOS, PMOS, they don't have periods at all. The second is evidence of androgen hormone excess. So androgens are hormones that both men and women make. In PCOS, some women make too much androgen hormone, and that also contributes to irregular periods, but it can lead to other skin features, particularly dark skin around the face or around the body. And we have a specific criteria to categorize hair over the body in a female. It can also, high androgens can also lead to hair loss. And the third is polycystic ovarian morphology on a scan. So when you're having a pelvic ultrasound scan, there's specific things that the scanning person will look for, and they will say in the scan report whether your ovaries look like PCOS, and you need 2 out of these 3 criteria to diagnose PCOS. So for this patient, she had got 2 out of 3 of these criteria before I had actually even seen her. The gynecologist had arranged these tests. So it's a really important diagnosis that needs to be made properly. Now, how common is PCOS or PMOS? It's extremely common, in fact. Around 1 in 10 women worldwide is thought to have features of PCOS. So it's amongst one of, if not the most common hormone abnormality in women of a reproductive age. And over the last few years, we have begun to understand that PCOS is not just about irregular periods, it is related to long-term metabolic health. And yet, for years, many women have been told, oh, your periods are just irregular, just lose some weight, or just take the oral contraceptive pill. But no one actually explains what is happening, why are all of these problems happening together? Because actually, the ovaries are just one part of this story. So what is actually happening in PCOS or PMOS? Well, the genetics here are similar or the same as type 2 diabetes. And the basis of this disease is insulin resistance. And you've heard me talk about insulin resistance pretty much every day for the last 3 years. So what is insulin resistance? Insulin is the hormone that allows glucose to move into our cells from our bloodstream. So glucose in our bloodstream moves into our cells, and when somebody becomes insulin resistant, the body has to produce more and more insulin to control the blood sugar. High circulating insulin is the result of this problem, and high insulin has consequences. It leads to some of the features that we see in PCOS, which include weight gain, feeling hungry. A lot of women with PCOS feel a little bit premenstrual all the time. Also, insulin reduces the liver's production of SHBG, which is a protein, and when SHBG levels are low, the androgen hormones that we mentioned can become relatively higher, and that the high androgens can contribute to irregular periods, irregular ovulation, acne, facial and body hair like we mentioned, scalp hair thinning, and difficulty conceiving in some women. But remember, insulin resistance is a metabolic problem. So this can contribute to the weight gain and the prediabetes, type 2 diabetes, and heart disease risk, which is so important. Now remember, not every woman with PCOS has obesity. Not every woman with PCOS has insulin resistance, but it is the vast majority of them. And we should be very careful not to reduce PCOS simply into a woman's body weight. It is actually much more complicated than that. So now let's come to the mother-daughter connection. This is why my patient's case is so striking. She's 26 years old, and she has her mum sat next to her who already has type 2 diabetes. So whenever I see a woman with PCOS, and they have a parent or a first degree relative that has type 2 diabetes, I sit up and pay attention, because family history really, really matters. An HbA1c of 6% is not something I want to simply dismiss because she was young. It is an absolute opportunity to warn her, to help her change, her metabolic fate, because if she carries on like this, she will develop type 2 diabetes, probably even in a matter of months or years at the latest. Because this is a very different conversation that is happening at 26 versus if she was 46 or 56. Because PCOS is about long-term health, I want to think beyond periods and fertility for women. Women with PCOS have an increased risk of developing type 2 diabetes, but we should also pay attention to other things like blood pressure, cholesterol, obesity around the tummy or visceral fat, fatty liver disease, even things like obstructive sleep apnea, fertility, which we will go on to discuss, and psychological well-being, because this is something that I've been seeing in my clinic hundreds, thousands of times over the last 20 years. And some women just say, doctors, my periods are irregular, but actually what I am thinking about is their whole future health. So what can we do in PCOS? What can we actually do? Well, it depends on what the problem is that the woman wants to fix. So, is the problem actually mainly irregular and unpredictable periods? Is the problem acne or facial hair? Is the problem prediabetes? Is the problem weight? Or does this woman want to get pregnant? Because the treatment depends on the goal that she wants. So, the treatment options in terms of medication are metformin. So metformin is a medication you will all have heard of. One of the most common brands is glucophage. This is the first prescribed diabetes medication worldwide, and this helps specifically with insulin resistance. So this is one drug that I consider particularly if a woman is planning to conceive, because it can help with menstrual irregularity, and if a woman has regular cycles, it kind of helps her track her cycles, and that's one barrier that we have overcome if she wants to plan to conceive. It is not a magic weight loss tablet, and it's just one tool. It needs to go along with lifestyle modification, so diet, exercise, sleep, eating well, getting rid of sugar, getting rid of processed foods, eating whole foods, increasing fiber in the diet, increasing protein, so many things. And I recommend all women with PCOS actually see a dietitian. So the next treatment option is the combined oral contraceptive pill. Now this can be useful. It's not for everyone, but it can be very useful if a woman is having heavy, irregular or painful periods. It can regulate bleeding, it can make bleeding more predictable, and crucially, it can reduce the high androgen hormones. So there's many different types of pill out there. You have to find the pill that will suit you. Often for women that have high androgen hormones, there are 2 or 3 specific types of combined oral contraceptive pill which we will consider. And again, this requires a lot of counselling, and we have to look at things like body mass index, smoking. And remember, this patient of mine, she had a BMI of 39. She actually was also a smoker, so the pill would not be an option for her. And things like family history or personal history of blood clots, because we want to avoid the combined oral contraceptive pill in somebody who has a history of blood clots, is a smoker, or who is very big with a high BMI. Now, moving on to slightly more specialist treatment, you may have heard of spironolactone or other anti-androgen treatment. This is something I prescribe very rarely. It is off-label treatment for PCOS, so it is actually not approved treatment for PCOS, and I'm very upfront and I tell all of my patients that spironolactone is actually a blood pressure medication, and the side effect of it is it can help to reduce the androgen hormones interacting with androgen receptors. So it's quite a complicated way of it working, but in some women that have very increased hair growth or hair loss from the scalp, particularly around the sides of the scalp, spironolactone can work reasonably well. It is not a magic treatment, and it takes about 6 months to really see the full effect, but I've had a few women on it who it has helped. But the most important thing is women that are taking spironolactone, they must not conceive, because this has potential damaging effects if they conceive, particularly if it is a male fetus. The second anti-androgen treatment is finasteride. Finasteride also blocks the action of DHT hormone, which is an androgen hormone, and again, same issues with a woman who might inadvertently conceive. She cannot take finasteride or spironolactone without good birth control, because we never want a developing fetus to be exposed to these 2 drugs. Now, moving on to weight loss medications, I have many videos about the weight loss medications. I prescribe the weight loss injections, the GLP-1 injections, to women with PCOS relatively frequently, I have to say, because the GLP-1 receptor agonists, or the GLP-1 injections, work very well for insulin resistance. Remember, these are historically diabetes medications, and they work very well with PCOS, insulin resistance and weight loss. They can help a little bit with women that suffer with cravings for food or sugar cravings, or women that have very big appetites. So yes, it is a very good tool again, but it is not that I'm treating PCOS with an injection, because again, the same issue happens with PCOS, that conception whilst taking these injections is not advised. And in fact, I tell all of my women who are using these GLP-1 receptor medication to stop these 3 months before planning a pregnancy. So what can women do themselves? I've mentioned some of the basics of the drugs, but what can women do themselves? Of course, many women with PCOS have been told to just lose weight, but actually that's not so easy, particularly if they are not sleeping well. Now, this patient of mine, going back to my case, this 26-year-old of mine, she was only sleeping 5 hours a day. She was staying up till midnight or 1 a.m. and getting up at 5 or 6 a.m. for work. And the other thing is, she has a very sedentary job. She works as an architect. So she's worked super hard in her life, done some really difficult exams and a really difficult degree, and basically now sitting in front of a computer for 8 to 10 hours a day and not getting enough sleep and getting virtually no exercise. So this is a really crucial aspect of her diet and lifestyle that she needs to address. Remember, poor sleep affects every aspect of metabolic function. It increases your insulin resistance, it increases your hunger hormones, it reduces the hormones that keep you full. It can also, like, if you're tired, you just don't feel like exercising and you're more likely to reach for convenience food. So number 2, moving on, is exercise. What can women do? Anything, any exercise that a woman will do is beneficial. So anything that you're going to do coming from a place of no exercise, any exercise that you will do is beneficial. So that includes walking more, gentle exercise. So I found that in PCOS, very hard-hitting, high-intensity exercises tend to stress the body out more. So I would recommend gentle, consistent exercises. So that could be walking indoors or ideally walking outdoors when the weather permits. Gentle resistance training, remembering to breathe, remembering to stretch, avoiding injuries, and trying to build muscle. Women with PCOS that have high testosterone or androgen levels actually find resistance exercise quite beneficial. Number 3, looking at the food environment. We really need to discuss getting rid of processed foods, getting rid of sugar, seeing a dietitian, as I mentioned, and eating only whole foods and focusing on protein and fiber, because fiber will help to reduce cholesterol and blood sugar, and protein helps to build muscle. So I want you to think of eggs, Greek yogurt, fish, chicken, tofu, lentils, vegetables, salads, nuts, seeds. This is, the whole food diet. You don't need to observe any particular diet, but you do need to be careful about your diet when you're taking GLP-1 medications. Remember, there is no single magic PCOS diet, but I do often discuss low-carb diets, and I have videos on this as well. Now, a lot of people have heard about inositol and spearmint tea. I get asked about these supplements all the time. Inositol can be considered by women who want to use it. There is a bit of evidence that it can help regulate periods and maybe help with conception. But again, this has to be done with all of the diet and lifestyle changes I've mentioned above. Inositol is pretty expensive. It's generally safe. I don't think anyone really knows the best dose that an individual needs to take, and I really use it as an adjunct. It is probably not harmful, and some women see benefit, but I would highly recommend focusing on all of the other things first before you start using inositol, because if you haven't fixed the basics, inositol is unlikely to do a lot of good. And lastly, spearmint tea. Some small studies have actually showed that spearmint tea can help to reduce some of the effects of the androgens. Again, it's an adjunct, it's something to use along with all of the diet and lifestyle changes I've mentioned above. Spearmint tea alone is not going to reverse somebody's pre-diabetes. So an important message about fertility. PCOS does not mean you cannot have children. But PCOS can lead to infertility, it can lead to trouble conceiving, and it needs to be treated before a woman falls pregnant. So particularly relevant to my case is she needs to improve her blood sugar, lose some weight, regulate her periods before she conceives, because if she conceives as she currently is, that will be a higher risk pregnancy with an increased risk of miscarriage, gestational diabetes, and pregnancy complications, as well as potential complications for any developing baby. So back to my 22-year-old patient. Just to summarize, this was a 22-year-old architect who has gained 15 kilos over the last 2 years. She's been referred by gynecology because they were worried about her blood sugar. She had an HbA1c of 6%. She's doing no exercise. She's sleeping around 5 or 6 hours a day only. She's eating convenience food, and she has a mother who already has type 2 diabetes and is on treatment. I don't want this to sound like a depressing story, so what have I done for my patient? Well, I've referred her to a dietitian. I've counselled her extensively about all of the medication options for her. It's likely for her that we will try the GLP-1 injections because she has quite a lot of weight to lose with a BMI of 39. We will start her probably on the GLP-1 injections and try with a gentle, consistent weight loss journey over the next year or two. She has a partner and she's thinking of getting married in the next couple of years. She's still young, we still have time, but we want to give her the best chance of improving her health before she gets married and starts to plan a family. So if you're watching this and you've been diagnosed with PCOS, or you know someone with PCOS, I want you to think about PCOS very differently. When you go and see your doctor, I want you to say, what is my HbA1c? Can we do some blood sugar blood tests? Can we do cholesterol profile? This is my family history. I want to know if I'm ovulating. What about my long-term health? When can I start to have a family? Which of these medications do you think is a good option for me? Remember, if you have insulin resistance, PCOS, prediabetes, type 2 diabetes, menopause, or any other hormonal issues, and you want to get in contact with me, just comment down below. My team will be in touch. Make sure you follow me on Instagram. You can also WhatsApp me from my Instagram profile. Someone will be in touch with you immediately. You can learn how to work with me one-on-one. I have so many other resources, ebooks, meal plans, online videos. Go and look at the videos that I have already on Instagram. And if you want to get in touch, then please do. Many thanks.